Good afternoon. I am Stacy Allen, pharmacist consultant with the Kentucky SOS program of KHA. Thank you.
All right, absolutely. Welcome everybody, and thank you, Stacy. I really appreciate it. It's good to be back. Happy New Year to everybody. Hope everything has been going well. Lets me know how much with the intro, how much has changed over the last few years since we started this Kentucky SOS project. As many of you are aware, I've been the participant and advisor for the emergency department side of the acute pain management and looking at the metrics with the alternatives to opioids in our emergency departments. And this is actually one that we've gotten some of the most questions about, and that's the pain management of ankle sprain. And so we're going to dive into that. My goal as an emergency physician is that we are not going to take the full hour, which leaves plenty of time for you to ask questions. If you want to throw questions up in the chat, I do have it up here on my side screen, but otherwise email whatever it is, questions that you may have as we jump into the topic. So really, to give just that general overview, the opioid epidemic is still the greatest drug epidemic, minus alcohol, in the history of the United States, with over 1 million American lives lost since 1999. And we started to make progress heading into COVID, but then, of course, COVID derailed a lot of everything, but including the opioid efforts, and we saw those numbers jump right back up again. I still remember when we just panicked because it was getting close to the numbers associated with motor vehicle collisions, and now we've elapsed that several times over. The early years, of course, driven by opioid prescribing, and it does continue to play a role, and there's a role that we as physicians, practitioners, and others can play in the prevention of opioid dependence and opioid use disorder. But it's also now has transitioned. It's one of those things that you start the fire and you think it's under control, and then all of a sudden it starts to spread, and next thing you know, the whole forest is on fire. That really is where we are now with that transition from prescription opioids to heroin and now to fentanyl. And so this is something that continues to grow, crossing that 100,000 mark for overall overdose deaths across this country. And there's stuff that we can do about it, and especially ways that we can prevent future addiction and the loss of lives. Of course, we got to start off with conflict of interest. I don't have any conflict of interest in terms of any payments or associations with any of these things that I will be talking about today. So this is just something that's been a passion for me since finishing residency and starting speaking at the Emerald Coast Conference, which was then the SEC conference, about the opioid epidemic from the viewpoint of Kentucky being one of the epicenters of the opioid epidemic. So here's what we're going to look at. Let's do just an overall review of the incidence of ankle sprains. And this isn't a talk that's going to talk about the opioid epidemic. We will talk really about some of it, but the majority of that I've already done. We're really talking about more the kind of the focus on ankle sprains, as well as some of the evidence in terms of pain management, the ankle sprain physiology, some of the acute pain management of ankle sprains, the evidence in management, and of course we'll have plenty of time for questions. But really, what I want to focus on here, and why we continue to have discussions and talks and challenges in changing the way, is it's easier to have not done something in medicine than to change it once we're already doing it. And that really is where we are. We have gotten this, and whether it was intentional with the pharmaceutical industry or whether it was just the combination of everything involved, we as healthcare, as physicians and healthcare practitioners, got in this mindset that things like acetaminophen and ibuprofen and naproxen are medications for fevers and minor pain. And then if you have severe pain or significant pain, then you're talking about needing an opioid. And this really is about changing the paradigm and refocusing on that evidence to say, what does the evidence really say? And if I could give you any message to take home, it's the fact that opioids don't treat anything. They cover it. It's like when you're a child, and you were worried about the boogeyman or ghosts in your room, you covered yourself with a blanket because that way they couldn't see you. And the only reason, I think about that is my daughter's been having nightmares this week. But, the idea that, just throw the covers over it and you don't see it, so it's not a problem anymore. And it does have a role. It has a role in terms of some areas of pain management, especially if there's some sort of contraindication to other modalities. But really, it's very narrow compared to what we've done in the past. And it may not be primary. It may be a secondary or a tertiary consideration. And so we just really have to refocus that whole paradigm that acute pain, even if severe, means opioid. It doesn't. And what you'll see, and we'll talk about some of the evidence that shows that in most cases, in fact, the vast majority of cases, that non-opioid medications and therapies are as good, if not better, and safer than the opioid alternative. But again, not a complete strickening of the opioids. It still has a role. We just need to make sure we put it in the place where it is. We don't drive our fancy V8 sports car every day. When it's snowing outside, maybe it's a time for the other types of vehicles. So let's take a look. These are some of the sources that I really dove into, and I think I wanted to make sure that this was here because these are both really good summaries. Of course, Up to Date is going to be the subscription-based service, but many of our hospitals are going to have subscriptions and something that you can access this. The nice thing about Up to Date is it continues to have, it gets reviewed on a regular basis. In fact, I think it was reviewed last in November of 2022 with the updates. And so it really kind of marches through a lot of things, of course, with the resources as well. This one above it as well, the Ruiz-Sanchez article on the management and treatment of ankle sprain according to a clinical practice guidelines, or PRISMA systemic review. That one's from October 21st. So it really is about making sure that we get everything as much, the resources as much up to date as we possibly can. So this is a really small chart, but this is the summary of the Francisco Ruiz-Sanchez on the systemic review. And basically this took not only the rules and how we diagnose. So the first column on the left is going to be the rules that we use to determine if imaging is even necessary and the evidence that is there. If you're used to review of evidence, you have the level A, the level B, the level C. And starting with A, there's a lot of strong evidence. B, there's some evidence. C, we're getting to the more of kind of the conglomeration, and D, potentially even just opinions. And so what we're looking at here is moving over, is looking at some of the therapies in functional. You know, remember with ankle sprains and with most types of bony injuries and soft tissue injuries, the idea used to be immobilization, stopping all movement. We're knowing now that especially with ankle sprains and others, that we're looking for functional mobility, allowing the body to start to recover, to get back its function, because if we don't use it, we actually lose function, lose stability over time. So that ambulation, the idea of cryotherapy or cold, the use of ultrasound, the use of electrotherapy, things of that nature. So those are some of the bases from that standpoint. But if you move your way over onto the right, we're looking at things such as NSAIDs and opiates. At no point does an opiate get a high level recommendation, but we do see that our NSAIDs are going to get A and B level recommendations. Even surgery has some higher recommendations than opioids. Rehabilitation has higher recommendations than surgery does. Than opioids do. So in terms of the recommendations, we're seeing even with ankle sprains that that opioids are going to be a tool, but they're not going to be the primary tool. There's a lot of other tools and not just medications. They're going to help our patients get better. And my last patient that I had last night in our emergency department was an ankle sprain, and sitting down and talking with them about the symptomatic management, expected course, follow-up instructions, you know, how we want to do the functional mobility, those things of that nature. It really does take that, having that discussion with those patients and their families to help them understand what to expect. Now, of course, it's easy for me, being somebody who used to play basketball. I have my fair share of ankle sprains, understanding that some are going to last a few days, some are going to last a couple of weeks. I had one that lasted 3 months. And the symptoms and management and how to get those acute symptoms taken care of the first night where the swelling is there and you start to get the significant pain where you feel like you can feel your pulse in the ankle. You know, those types of things are kind of getting through that expectation of what they're going to feel. So let's take a look at the big picture. Although there have been very few trials of patients with acute pain treated with opioids compared with placebo, so that direct comparison, and that's probably purposeful, the overall the magnitude of benefit is small, while the adverse effects profile is sufficiently high that this resulted in the recommendation of being downgraded. So this is the course of opioid prescribing for a new episode of disabling low back pain, so a different type of pain but one of the most common ones we see. And so there really were, in this case, 4 quality trials of acute pain treating opioids compared with placebo, with small overall magnitude of benefit, where the adverse effects were pretty high: the somnolence, the constipation, the risk of fall, the nausea and vomiting, GI manifestations that may be there. Among the trials for treatment of acute pain, ibuprofen was reportedly superior to codeine or acetaminophen for acute injuries, including fractures, and then others were a comparison. So, I mean, we're equivalent. And so in this case, the idea being, when needed, the lowest effective dose of short-acting opioid is recommended with acute severe pain, uncontrolled by other agents such as nonsteroidal anti-inflammatory drugs. And what I tend to do myself, my personal practice, is putting together the acetaminophen and the NSAID up front as soon as they arrive. So that patient that arrived last night, as soon as they got there, got an NSAID, got a Tylenol, then got their, they didn't meet the Ottawa ankle rules, so because they had some foot pain as well, and some focal tenderness, bony tenderness, so they got an X-ray. And then by the time everything was said and done, they had significant improvement. And also that messaging that there is no expectation of pain-free. If you think about how opioids are impacting patients, it isn't because it fixes the problem. Again, it masks it. When we're talking about acetaminophen, we're talking about NSAIDs, that anti-inflammatory aspect of things. It does decrease that inflammatory process, especially with the NSAIDs. We're talking about opioids, we're covering it back up. And in fact, it starts to upregulate in terms of that sensitivity. And really where you get benefit, if you think about it, when somebody is really decreased pain, it's some of that, so sometimes the disassociation, sometimes the somnolence, sometimes it's just kind of taking your mind off of it. And so it really isn't doing anything to the pain. It's still there. The process is still there. And what we're trying to do is not only get something that's safer on board, but then ensuring that we're actually doing something that's going to benefit the patient's outcome in terms of the injury itself. So an ankle sprain is the most frequent musculoskeletal injury in athletes, very common in the general population, with secondary conditions as well. So, of course, it's going to cause pain, restricted range of motion, leading to functional deficit or disability, some osteoarthritis risk, chronic ankle instability. There are some signs that persist at 1 year for up to 44% of patients. And that one ankle sprain that I had that last several months did have some discomfort, not much, just some sense for that year. And that's not quite sure exactly what is going to be the risk factors. I think, of course, the degree of sprain, the degree of the injury. When I had my last ankle sprain, my lateral malleolus actually hit the basketball court. And so you could hear it like it was knocking. And so that's not supposed to happen. So that significant inversion injury, that the foot inverted enough that the lateral malleolus hit the floor. Ankle sprains account for about 12% of all injuries seen in the emergency department and up to 30% of all sports-related injuries. So very common, especially basketball. A take-home message: don't wear narrow-soled shoes like Pumas while playing basketball. That was my take-home message. For my incident, I just thought I wanted to play basketball. Come to find out, you shouldn't do it with those type of shoes. They're known to account for 45% of injuries that occur during basketball, 31% during soccer, so significant risk. Certain sports, much higher likelihood. Likewise, 29% of all injuries to lower extremity in soccer affect this joint, 75% of them to the lateral ligaments. The lateral ligaments, the inversion injury where the foot comes in, is the most common. You see that all the time. They love those slow motion replays in football and soccer and basketball with that good inversion injury. You see him come wobbling back up. So again, significant decrease in range of motion, incredibly popular. So we're going to see this one. That's why we picked it as part of the Kentucky KYSOS. It's a low-hanging fruit. It's one where we can very easily, for the most part, decrease the dependence upon opioid therapies. So just a breakdown of the anatomy. There's 3 ligaments on the lateral aspect of the ankle, or the outside of the ankle. The anterior talofibular ligament is the one that's most commonly impacted. I noticed that their ATL, they listed it twice on this. This is a stock photo, but the first ATL, the anterior talofibular, is supposed to be the ATF. That is the one that's most common. And what happens as with that inversion injury is it starts to is it starts to rip from front to back or strain from front to back. So you're going to see that initial swelling and bruising on the more anterior aspect of the lateral ankle in most patients. Then the calcaneofibular ligament and the posterior talofibular ligament is the third that gets torn. On the medial aspect, one larger ligament called the deltoid ligament that gets strained. Again, an eversion injury with the foot going out is extremely rare. It typically, a lot of times, is associated with a fracture of the fibula, not just because the fibula sticks down a little bit further and it's a more sensitive bone to those types of breaks. With the tibia and the inversion injury, it is a stronger bone. If we do see a fracture there, a lot of times it's going to be from just the medial malleolus on the tip of the tibia there, which is a little bit more narrow. So the lateral is going to be much more at risk as it's with these types of injuries than the natural physiology of the foot. The ATF is the number one injury or the number one ligament that is injured with association of these ankle sprains. So let's look at the metric. What are we talking about with regard to Kentucky SOS? So this is the metric right here. Emergency department opioid use for ankle sprains. Patients age 18 and older prescribe no opioids during an emergency department encounter for specific pain-related condition. Looking at these to say, when an ankle sprain comes in, can we do this management without any opioids? And I say absolutely yes. As somebody who's probably had 5 or 10 different ankle sprains, I've never taken anything significant for it. They can be very uncomfortable, but again, pain is an important aspect and discomfort is an important aspect of safety. What I don't want to do is do anything like a nerve block that will insensate the person and allow them to do things that could further damage. And as I mentioned to a lot of my patients, I can make you pain-free with opioids, but I may not be able to keep you breathing during that process. There's a point in which there's that crossover. And with the non-opioid, we are increasing that safety while still giving them symptomatic relief to the point that they can still function. And that's the goal. Where we were taught for so long that people deserve to be pain-free, if you're over 18 years old, especially if you're over 30 years old, there's very little that's pain-free. Every day you wake up and you're a little bit sore. And I woke up this morning and my wife had one of those little portable things around her back, the heat massage thing, talking about how she slept wrong and the back hurt so bad. So, each of us has those types of things as we grow up and grow older. It's just a natural part of life. Now, our goal when we're treating all these conditions is that we want the patients to be comfortable and to be able to do their activities of daily living. That's why I think sometimes the treatment associated with may differ at night than it does during the day. So in instances where I use an opioid, I typically talk to the patients and their families about saving it and using it only at night when it may be more distracting, may diminish their sleep. During the day, I think many of us can tolerate a little bit more. But again, we're still talking about the idea that the modalities that we're talking about are actually as effective as an opioid, just with a little bit more safety to it. All right, so this is the typical type injury, and this looks kind of like me right here. So as I mentioned, some of the best experiences, that personal experience, I think as a physician, some of the best times you can relate to a patient when they come in, they say, well, you don't know. Like, well, actually, I do know exactly what you're talking about because I've had a significant sprain. So actually, I was an emergency medicine resident, University of Kentucky, went to the fitness center there and was working out and thought I'd just do some pickup basketball. Unfortunately, only had on my Puma shoes, which I like to have those Puma shoes in the hospital because they're pretty comfortable for walking around the hospital and they're great for even surfaces. What they're not good for is uneven surfaces and for sports, especially anything like basketball. And I still remember coming around that turn after a rebound, coming off the wing, and I plant my foot and it rolls out, and I heard my lateral malleolus hit the floor. And immediately the ankles swelled up. I went in, I had a shift later that day, put on an air brace, one of those air splints, had them do a quick x-ray on it just to make sure that nothing was broken. And then, for me, that was tolerable. But then, of course, went home that night. It was significantly swollen, had the throbbing overall at night, wrapped it pretty tightly with an ACE wrap to decrease that inflammation because a lot of the pain associated with an ankle sprain is that stretch, swelling, expansion of the ankle itself. And so a lot of our nerves aren't necessarily what you say going to be more of a touch type of pain receptor. A lot of times more they're baroreceptors, or feeling that stretch or that pressure change. And that's why people, when you've had a history of a knee replacement or a knee injury, you can feel the changes in the weather coming. The reason you can feel that is because the changes in the pressure and the associated expansion or contraction of the actual synovial capsule. And so with that swelling, that's where a lot of that pain comes from, the swelling, the bruising, and the strain. If we can get some pressure, we can get some stabilization, then with some medications involved, we can actually make a significant impact on the symptoms that patients are going to have and the experiences they're going to have after an ankle sprain. So looking at the ankle sprain, estimated 9 million ankle sprains occur in emergency departments from 06 to 15. 56% got NSAIDs, 28% got an opioid, and those were the two most common medications that were provided. Now, the interesting thing would be, what are our numbers now? The numbers now suggest it's not as high, that we've actually cut that back a fair amount. But think about it, 28%, so 1 in 4 patients. And if you've done and seen one of my talks before, you know that about 1 in 12, about anywhere from 8 to 12% of opioid naive patients will go on to some form of dependence or recurrent use of an opioid. So, the number needed to harm with an opioid is not large by any stretch of the imagination. 2018 population-based study found that 25% of opioid naive patients, just rolling off of that comment, with ankle sprains received an opioid prescription. Opioid naive. And that's important because now we're talking about people that otherwise, without this injury, would not have had an opioid-based exposure. A recent review of 14 studies with over 13 million participants found that 6% of patients prescribed opioids for an acute musculoskeletal injury developed some sort of persistent opioid use. That's huge. And so even if we're saying 6%, so for if I've got 100 patients that come in, 6 of them are going to end up with some sort of long-term use. Think about the incidence with 12% of ER visits injuries associated with an ankle sprain. Translate that to 6% if we're prescribing an opioid. So let's just say, basically, in this case, we would, with 100 patients and 25% receiving some sort of opioid prescription, or somewhere around a 1.5, 1.75 of the patients, of every 100 patients we're going to see, are going to end up opioid dependent, just based on the statistics that you see here on the screen. So for us, this is a huge potential impact of small incremental changes and decreases in the opioid prescribing. Even the course, even the dosing can make a huge potential outcome in our population health. So looking at the Cochrane review, the oral nonsteroidal anti-inflammatory drugs versus other oral analgesic agents for acute soft tissue injury, which this is considered a soft tissue injury because it is a ligamentous injury and not an actual orthopedic. A fracture is a different story. Even then, a lot of the fractures, especially peripheral fractures, can be managed without significant opioid. But this is one that's from January of 2021, published online November of 2020, but went on, that it was actually published a couple of months later. What this one found, it reviewed 20 randomized studies with about 3,300 patients, mostly with ankle and wrist sprains. So looking at kind of the area where we are right here, no difference between opioids and oral NSAIDs in terms of reduced pain in the short term, nor did they find any difference in pain relief between NSAIDs and acetaminophen. That was a very high certainty evidence there. They did find a higher incidence of GI and neurologic-based adverse events in the opioid group compared with NSAIDs, and slightly fewer with GI adverse effects with acetaminophen compared with just NSAIDs alone. They found NSAIDs were superior to opioids for return to function after injury. So that's really one of the key take-home messages. When somebody comes into one of our emergency departments, I want to relieve some of their discomfort, much of their discomfort. But I also want them to be able to get back to life as quickly as possible, whether that's school, whether that's sports, whether that is work, whatever it may be. And there's been a number of trauma-based studies that opioids actually delay the return to normal life function. So when we prescribe an opioid, we have the potential that we're actually going to prolong their recovery. And back pain studies have been done that demonstrate the exact same thing. When prescribed opioids, they're less likely to be active, more likely to still complain of ongoing symptoms. And so this is a really good summary study with the symptoms that we're seeing, with the disease process that we're dealing with now, with wrist and ankle sprains, of how NSAIDs are not only equivalent, they're superior and much safer than our opioid-based therapies. So now what do we need to do? When somebody comes into one of our emergency departments, there's a few things that we need to consider. First and foremost is, do we even need imaging? Now we have MIPS. MIPS has been, the quality-based measures have been from CMS, have been delayed for several years. They're going to be delayed at least one more year because of, the COVID-19 that was just announced earlier this week, that they're going to be delayed once again. The thought is in our community that they may or may not return. They may have something else that comes out. And I can guarantee you the government's going to come out with some other hoop for us to jump through. But there's some great tools out there. The Ottawa ankle rule is one that looks at the likelihood of a significant fracture or injury and whether we need to actually even do the imaging studies or not. Now, I find it's easier to determine if I need an x-ray versus convincing a patient or a family member that they need an x-ray. Everybody knows with the imaging ankles, wrists, and that sort of thing, especially, CT heads with minor head injuries, we know the likelihood of a significant finding is super low, and the rules may support us, but convincing the patient or family member can be very difficult, especially when they're coming in saying, I need a CT scan to rule out a concussion. It's not how it works. So acute pain management, what do they need? So as I mentioned yesterday, my patient comes in, actually had a wrist sprain and an ankle sprain is some of my last patients last night. So what do we do? Acute pain management, I hit them with some acetaminophen if they haven't had it already, as well as an NSAID almost right off the bat if there's no contraindications. Contraindications being such as, chronic kidney disease, chronic renal failure, significant bleeding issues in the past, especially GI-related bleeding. Just because they're on a anticoagulant is not a absolute contraindication. It's a indication for long-term NSAID use, but not necessarily for the short term. And then mitigate the swelling. As I mentioned, that is one of the main causes of the symptoms, is that swelling around the ankle. So how can we decrease that? With a wrap, so an ACE wrap, compression bandage of some sort, as well as ice. We're moving away from this RICE therapy, even though I'm going to mention it here shortly. The RICE therapy, the rest, the ice, compression, and elevation. We found that ice, especially longer term after that initial swelling period, decreases the recovery processes, decreases healing, which makes sense. But then that initial swelling process, that initial body realizing there's an injury and sending in inflammatory markers, we can decrease that. And the more we decrease swelling, the more we're going to decrease some of that discomfort. Splinting or immobilization. This is a big topic. Do we need to completely immobilize, or where do we do that? Ankle sprains are in 3 different grades, grades 1 through 3. A grade 1 would just be considered a very minor ankle sprain. And sorry for the background, my secondary screen here just keeps deciding it wants to shut off and turn back on. But the grade 1 is the very minor. This one probably doesn't need much of anything. This one's one that a little elastic wrap or an ACE wrap, whatever it may be, just for a little bit of stabilization. I'm finding that most ankle sprains are going to fall into this one. Grade 2, which is a more severe, probably more of what I had, is going to be something more like an air splint, which is one that stabilizes those ligaments. These ligaments are actually used, and you don't realize how important they are until you don't have them or they're not functioning properly, in keeping us upright. And you don't realize how much work they do until you don't have them, and then you feel like you're just going to constantly fall or your ankle's going to give way. And so using that air cast air splint, it replaces and stabilizes those ligaments in terms of keeping the tibia and fibula over the foot. And so an air splint, an elastic wrap, even a figure of 8, if you're looking at some of the PT type possibilities. And then a grade 3, these are the ones that are severe, probably a tear, significant disruption. They may or may not even require surgical repair versus a functional rehab. These may be initial case of or timing of non-weight bearing or minimal weight bearing plus splinting. And so this may be the one we may use a boot. I may just use an air caster with crutches. Depends on their baseline mobility. If they're young and otherwise stable, may do some crutches in order to give them some relief. It really is, in this case, do as your foot and ankle tells you that you can do. What is the tolerance of the activities that you're doing? The key here is functional splinting, though. Working with the shoulders, elbow, wrist, knees, and ankles and feet, for the most part, without a fracture being present, it really is about functional splinting, allowing the body to do some movement, but assisting it in stabilizing. It's just like physical therapy, holding the person by the belt as they move around. They want the person to walk and do the motions themselves, but they're there for stability. And that's exactly what we're trying to do, is that functional splinting, whatever's necessary to allow it for them to do their activities of daily living as best as possible. Splinting and immobilization is going to be key on grading. What is the grade? Now, we don't expect perfect grading. I would just go with what's the severity in terms of the discomfort, the swelling, their ability to bear weight, those types of things, and really just kind of get that idea of what do I need to do to help this person to where they're not going to fall and injure themselves further or exacerbate the injury even further. So functional splinting, and I would say the vast majority of my patients are going to get some form of the air splint in order to help with that stabilization. Encouraging solid-soled shoes. The softer shoes, flip-flops, those types of things are going to make it very difficult, just because they don't do very well. And for those in healthcare that are still wearing those big old clogs, I used to wear the clogs until that ankle sprain, and I've yet to be able to wear them since then, just because the way they pitch your foot forward. Pain management, splinting. We know that, especially even with fractures, immobilization and splinting is going to be one of the main keys, one of the main players in decreasing discomfort. Early RICE, so the rest, ice, compression, elevation, then gentle and progressive range of motion. Medications, our primary is going to be the NSAIDs and Tylenol, but secondary, if necessary, in certain situations, especially if there's contraindication, for the primary is going to be short course, lowest possible dosing of opioids. But again, take home message. This actually went out last year in one of our messages from KYSOS, and something I wrote back then. This isn't about zero opioids. And I think that's where some people have gotten hung up a little bit with the discussion and with the rules, not the rules, recommendations and goals of KYSOS. It's not about zero. It really is about using the evidence-based treatments that demonstrate equivalent or superior efficacy with increased safety. We have to weigh both of those. And sometimes opioids will be necessary, but the patient should be transitioned as soon as possible. Shortest course, lowest dosing, and ideally, primarily with non-opioid based medications. Now, do we always, why do we focus on this one therapy as opposed to, harping on others? Well, the fact that we're demonstrating that 70,000 Americans are dying every year, and with the number needed to harm, each step we take may mean somebody is with us in 5 years or 10 years that would not have been with us if we had done otherwise, and their ankle would still have healed just fine. So this isn't a competition. The hospitals and systems, especially those with carpeted offices and leadership positions, this is not a competition. This program is built on the idea that we're going to raise the tide and thus raise all the ships. Consistent care across the Commonwealth so that our patients know what to expect when they go to one of our emergency departments. That if they go to Baptist in Lexington, it's not going to be significantly different than going to St. Joseph in Lexington, or wherever it may be. That we are evidence-based management. We know that if somebody comes in with stroke symptoms, we have a protocol that's consistent across the Commonwealth. If somebody comes in with a STEMI, a consistent process. If we have sepsis, there are consistent processes, expectations, and benchmarks that people need to meet. And we need to do the same thing with pain management, that opioid is not the easy button. And what we're seeing with a lot of our EMRs now and a lot of the ordering systems is they are prioritizing the medications based on first line, second line, third line, especially with common pain complaints, and especially with things like migraine headaches, and completely removing the opioids from the primary order set because they are not indicated in those cases. And so changing these practice patterns of our physicians, nurse practitioners, and PAs, and other practitioners within our facilities to lean towards the evidence-based treatments rather than what we had done through the end of the 90s into the early 2000s, and many ways continue to do so. If you look at my ordering set, I very rarely order hydromorphone. And if I do, you're getting admitted to the hospital. Because if we're going to that level of medication, that high risk of a medication, there's clearly something that's going to need some further evaluation and management and potentially surgical intervention. So we want to work together in this case. We want to decrease the opioid burden, treating pain. So this isn't about ignoring and not treating pain. This is about treating pain as well, if not better than we were before, and protecting patients at the same time. Is to take a look in the mirror, return acute pain management back to the evidence in these given conditions, away from where we were pushed back in the late 90s, early 2000s, and significantly dropping the use of opioids while still managing acute pain, and at the same time decreasing that likelihood of dependence, addiction, abuse, and unfortunately, for many people throughout our community's death. Because what we're seeing now is that transition is not very far from prescribing, from the prescription to the mu receptors and that increased pain, the increased tolerance and dependence, and driving its own demand to medications now, illicit medications on the street that don't give you a chance to hit rock bottom. What we're seeing right now with heroin, patients would use it, eventually hit rock bottom, and that's where they would seek recovery. With fentanyl and the potency and the amount of variability in what's on the street, unfortunately, many people who transition to that don't get that opportunity to recover. They don't get the opportunity to hit rock bottom. They unfortunately will suffer potentially a fatal overdose. In fact, right before I got onto this webinar, I was at a meeting downtown with the fire department about some overdoses, fatal overdoses that we've been seeing. And as soon as this is over, on a pain and addiction accreditation program for the American College of Emergency Physician call. So this is something that thankfully, with some of the decreases in COVID, we can refocus our efforts. So the idea is taking these small steps, starting with education and information. The systems that initially initiated these alto drops in opioid, demonstrated drops in opioid use, which continued to increase over 2 years. And so as the education, as the evidence, as showing the physicians and providers the evidence that is out there, we can move that needle and continue to move that needle. In these cases, the first 6 months, so about half the opioid use, which eventually grew to about 80% after a couple of years, and they were sustained and even grown a little since then, pushing that 90% mark. And the good news is better pain management per patient report, safer pain management, decreased door-to-door time, which we're all interested in right now. Everybody's strained, decreased return to the emergency department, even just as important for inadequate analgesia, and increased patient satisfaction. And if you're making a huge dramatic change, if you're one of these facilities that has been a very opioid heavy facility and you make these changes, you may have some complaints at first. There may be some patient complaints, but as soon as that education, that information, the evidence, the teaching makes its way out there, those numbers completely turn around. But it takes the support of administration, the C-suite, and everybody involved, and the expectation that this is how we're going to treat pain, and trying to narrow that variability within practitioner practice in terms of the pain management. I mean, the studies are out there that the opioid utilization is somewhere from about 4 to 5% up to about 26% in each patient encounter, with the only difference in outcomes being higher risk of dependence, use, and long-term abuse in those that are higher prescribers. So don't get caught in the weeds. I think that's what I see with the responses that we've been getting, is sometimes getting caught in the weeds. I know hospital administration and healthcare professionals, we dig way down in metrics. I mean, we're dealing with stuff that every facility, dealing with stuff with our facility, the volumes, the boarding, everything of that nature. We understand digging into the metrics, digging into the weeds. But in this case, keep it simple. We got to educate on evidence-based management of acute pain, provide the data on prescribing within your facility, track change. I think it's important for physicians and providers to know where they sit compared to their peers and where we sit over time, not only locally, but nationally. Theoretically, all of us are supposed to be reviewing our CAS reports to see our prescribing patterns. And physicians, many times not realizing that your non-physician providers and practitioners are falling under your license, and seeing where that pushes you, and educating them and educating others within our facilities. Set realistic goals. This isn't about zero. Again, it's not about zero. Advance those goals as they're met, just as we would an exercise program. When you turned January 1st, 2023, you didn't jump off the couch and run a marathon or do an Ironman competition. It's baby steps, it's small steps. And as we meet these goals, then continue to move that forward and set those goals and reward successes. Unfortunately, I think in healthcare now, we're really big into the punishment and not as much of the carrot. More the whip, not the carrot. We need to have those carrots there. We need to have goals. We need to have rewards. We need to make sure that our entire ED staff, front staff, acute care staff understands that we want them to succeed. And by them succeeding and having support, they're going to improve the care for our patients, and our patients are going to benefit not directly and indirectly as well. As this change happens, expand further along with us here at Kentucky SOS. We're looking at the initiation and placement of bridges now as well. You've seen the removal of the X waiver that has gone into effect. Some of the education information is coming up in June. So there really is no barrier now to not only helping prevent opioid use disorders, but also helping treat those that are suffering from opioid use disorders. We're continuing to advocate to make that easier. So the elimination of the X waiver, it is gone. And we'll see some of the education things coming up by June that they're supposed to announce, but likely will be related to your first renewal of your DEA, or your next DEA will require certain opioid-based training and addiction training. So we're trying to get that all put together. So summary, ankle sprains are common, 12% of ED injury visits. Evidence demonstrates that NSAIDs and acetaminophen are as effective and safer than our opioid therapies as first line. Opioids are still absolutely an option, but should not be the top tier. So ensuring that we put those in where they are. It's not a competition. It's not about zero. It is about going with the evidence and where everything is pushing it and pulling back from what was taught and pushed by multiple areas in the late 90s and early 2000s, and resetting the way we practice acute pain management in the emergency department. So as for me, easiest email, I see it's in the chat. You have my ASAP address, rstanton@asap.org, ryanastanton@gmail.com, @everydaymed on Twitter. We got the podcast where we have a lot of that, a lot of these discussions, and I'll likely pull the audio from this and make it available for emergency physicians around the country. Also, that the Pain and Addiction Accreditation is going to put this on their website as well, just because the education is key. And changing those practices is going to be one of the largest challenges we face. And so with that, I will accept any questions that you may have. Looks like you got about 15 minutes if you have questions for me. You can also drop it in the chat if you don't want to do that. So any questions? I will stop sharing so we can all see each other. IV Tylenol. So Scott.
Go ahead.
Yeah, Scott's got one here that's in the chat. When you say acetaminophen, are you a proponent of IV Tylenol? Absolutely. The big resistance to that I have seen in the past has been pharmacy, because initially the cost, if you're talking about something that's pennies versus something that was back in the day $20 a dose, which to me is still not really expensive compared to how much we spend on healthcare. But I think IV Tylenol, especially those that can't take PO, it's starting to build in its use within the hospital, not only as an antipyretic, but for pain management. It's used in surgery quite a bit. And so, yes, I think as able, if we can pull that in to the regimen in the emergency department, I'm hoping you're not putting in too many IVs with regard to ankle sprains, but with regard to acute pain management, where we're looking at things like renal colic, where we know we're going to have an IV, absolutely. I think if I can give a dose of ketorolac and a dose of acetaminophen IV in a patient that's been nauseated because of their renal colic, I think that's ideal. That's a fantastic plan. Anything else up there? They raise their hand, unmuted. Great turnout today. Really appreciate seeing everybody on there. And if you have any further input, questions, not only feel free to email me. If you have challenges, if you need individual education. I've done a lot of the renal colic education, not only here on Kentucky SOS, but to individual facilities to help their practitioners, physicians kind of see where that evidence sits. And I think as a physician, as myself, I want to see the evidence. If you're going to tell me to do something, I want to see the evidence as to why I'm going to do it differently than I've been doing it in the past, or why I need to add that to my practice. And so with that, that's, if we need that, if you need a physician to physician discussion, I'm happy to do it. Because it's, as the medical director here in Lexington, it's really heartbreaking to continue to go into homes and see young people losing their lives or significantly damaged because of the opioid use disorder and epidemic.
Well, we'll give everyone a few more minutes to type questions in the chat box, but I wanted to say thank you, Dr. Stanton, for sharing your knowledge, your expertise, and your personal experiences with us today. We appreciate you providing this timely talk for us. I wanted to remind everyone, go ahead.
And it's absolutely a response to the questions we're getting from you, from our hospitals, from our facilities. And so the whole purpose of this talk was because of the response and questions that we felt like we gotten enough that we need to kind of hit it from a more global standpoint. And so if you have other areas that you need us to hit on, absolutely send that in, especially as we continue and look to expand the program and resources and support. There's a lot of different things that could be. Kentucky Naloxone project is getting cranked up. A lot of things, and we continue to grow in ways that we can better be stewards and cater to our patients. And now, especially with so much of the changes in the documentation and billing and emergency medicine of those social determinants of health and the things that we need to do to help make sure our patients are as successful as possible, and not only in their safety and recovery. And so there's a lot of opportunity here that's not just the opioid and an ankle sprain. All right, I'll stick on. Everybody, I'll hang on here. I'll keep the chat window open. But otherwise, for all of you out there, thank you very much. I appreciate it. Have a wonderful day. Wednesday is what I hear it is today. Can't keep up on emergency medicine. But with that in mind, I hope you all have a great day. Enjoy this weather before the storms get here later today. And we'll talk to you down the road.